I think time is it? Go ahead. Okay. I'll be speaking about my approach to retinal vein occlusions. It's not moving. The
pointers are, the slides are not moving.
Page down. It's not moving.
It's like a painting.
Okay. Okay. So we look for, when we see a patient with retinal vein occlusion, most important to look for these systemic 4 major comorbidities and address these. Otherwise, there is no point in local treatment. And in younger patients, to look for inflammation, homocystinemia, blood malignancies, antiphospholipid antibody syndrome, and very importantly, medication like oral contraceptive pills and sildenafil. So unless we look at this, there is no point in starting injections. Very important ocular comorbidity is glaucoma. It's the chief ocular comorbidity with our retinal vein occlusions and can be missed very easily. So look at the discs very carefully bilaterally. It could be the other disc which gives the diagnosis. Once we know that it is a glaucoma patient, we start treatment for glaucoma and we try to avoid injection intravitreal steroids because that would increase the IOP. As well as when treatment for glaucoma starts, we request the glaucoma physician to avoid prostaglandin analogs and alpha agonists which can increase the incidence of macular edema. I've also found by patients with papilledema coming with vein occlusions in their subsequent visits, probably because of external compression by the disc edema. Now, retinal vein occlusions can be classified based on their location as central and hemiretinal superior or inferior, or one of the branch retinal vein occlusions. And the central and hemi can be ischemic or non-ischemic, and the branch can be major or macular branch vein occlusions. One of the most common is the non-ischemic CRVO and HRVO. They present as macular edema, which is generally well responsive to treatment, may be recurrent, but generally fewer injections than the ischemic variety, and good visual recovery. This is how they present, and generally good visual recovery, though recurrent edema is there. Ischemic CRVO and HRVO present with much more severe vision loss, extensive hemorrhages, maybe massive macular edema, or even absence of macular edema, but severe ischemia. And the vision remains poor even after the macular edema resolves because of the ischemia. So this is how they present. Even with the injections, the vision remains poor. But more importantly, in these patients, we have to be vigilant for iris new vessels and neovascular glaucoma, which can be a painful blind eye. Hemiretinal vein occlusion, in terms of proliferative complications, behaves like CRVO because of the larger extent of involvement and ischemia. In terms of macular edema, it behaves more like BRVO. So in these two, CRVO, HRVO, vigilance for iris new vessels, angle new vessels, highest risk used to be in the first 3 months earlier. But now, because anti-VEGF injections are given, the risk actually starts when the anti-VEGF stops after 1 year, 2 years, or 3 years. So the risk for new vessels, neovascular glaucoma can be much later. And even the non-ischemic cases are not safe. Often they progress to ischemic CRVO and go into NVG. So once you see a CRVO, they are not safe. For life, they are not safe. They have to be monitored for NVG. Branch retinal vein occlusion can have multiple macular complications, which I have listed here. Most common, of course, is the cystoid macular edema, which requires repeated injections. But hemorrhages can also compromise vision. Often, chronic edema develops ERM, which compromises vision. Even with treatment, sometimes they can go into macular hole because of the edema with poor prognosis. And presenting with macular hole, ERM. And another interesting feature of branch vein occlusion can be macular exudates, which ultimately cause irreversible vision loss. So they seem to appear when there has been long gap in treatment or a neglected case. And they also need more intensive intravitreal injections for resolution, more frequent, more number. And alongside is very important systemic control, especially the lipid control, but also diabetes and BP. So I would say prevention of this foveal center is very important because once they come, even resolution may not ensure good vision. It causes some permanent damage. So these are patients where neglected initially and then resolution with injections can happen. But vision doesn't improve. Once you have had center involvement, vision remains poor. This is a patient who did not have any treatment in the first 2 years despite counseling. So then came with massive exudates, and then we could resolve them with intensive treatment. However, not every case will resolve. Here we have tried all medicines. Initially, there was no treatment for 2 years despite counseling. And then we have, when he agreed after 2 years, despite even using all drugs, including faricimab, there has been a recalcitrance. And the vision remains 660. Also, BRVO presenting with macular ischemia, no edema. Here, there is almost no macular edema, but there is hard exudates which are going into the foveal center, approaching. So we treat here just to prevent the exudates coming into the center. That's what I do. I prevent exudates coming into the center so that we can retain 6/6. Proliferative complications with BRVO also common. You see silently sitting NVE, NVD. So annual retina exams for a BRVO is very important, for any RVO, but also BRVO. And if you see these new vessels on the disc which are silent, you have to start immediately. Scatter laser, which can be just over the involved quadrant, or it can be a pan-retinal laser sometimes required because new vessels do not regress with just sector scatter laser. So it may become a all quadrants pan-retinal photocoagulation. So annual review is very important for these silent new vessels. And here the patient has presented directly with NVD and vitreous hemorrhage in a BRVO which was otherwise asymptomatic, no macular edema. So BRVOs can also be deadly. And here post-laser, pan-retinal photocoagulation was required. Ultimately, the new vessels regressed. This again, they can present with vitreous hemorrhage. It's just a BRVO with ischemia at the macula requiring surgery. And now at least extensive scatter laser. Macular BRVO does not suffer from proliferative complications because it is a smaller area of involvement. However, the macular edema can be very recalcitrant, persistent, and they may not always have a good visual prognosis. RVOs may start looking normal over time, but if you compare the two eyes, you can see the tortuosity. If you see the octa, you can see in a branch vein occlusion, you can see the affected area. Imaging is multimodal, OCT being the cornerstone, but also fundus photography, OCT angio and fluorescein angio. You can see that OCT shows not only edema, but it also shows ischemia. And photography, if you see over 5 years of treatment, the edema looks the same. So if you were following only with OCT, there is no treatment, no benefit. But if you see the photographs, the hard exudates have gone. So there is benefits to photography. Angiography shows ischemia, new vessels, collaterals. Fluorescence still holds a place. For example, this patient came to me after several injections elsewhere, but he still didn't have a diagnosis. They were treating him as possible microaneurysm, circinate retinopathy, BRVO. So just one fluorescent and we got the superotemporal hypoperfusion showing BRVO. So now we have a diagnosis and we also know where to do the laser. The grid laser has to be applied superotemporally. Similarly here, a patient presenting like this, fluorescence shows that it's an inferotemporal BRVO with leakage, so this is where the laser has to be applied. So fluorescence has a very important role in many cases and also can pick up new vessels where their view is poor, even new vessels on the iris showing leakage on the right side. Treatment for all macular edema is and serial anti-VEGF injections, and secondary role is laser, steroids, vitrectomy. Anti-VEGF agents give very good results, and these are the agents available. Steroids are second line and not preferred because of the two complications, but also DEX implant, we have to be very careful when we use in patients who have a large PC opening or a scleral fixated IOL. This is my own patient, the second one from the right side, where it migrated into the AC, causing an emergency IOP rise and corneal decompensation. When to consider steroids? So this is only where anti-VEGFs may be contraindicated, such as in pregnancy, recent cardiovascular events, severe renal dysfunction, or where there is traction which can worsen with anti-VEGF. Macular laser for BRVO, just like DME, not very, very desirable, but may reduce recurrences. For CRVO, there is no role for macular laser, but of course pan-retinal laser. Follow-up of patients with retinal vein occlusion every 6 to 12 months is mandatory with undilated slit lamp exam for new vessels on the iris and angle. And fellow eye involvement is very important. Over every year should be checked. Silent RVO in the other eye is very common. You see this patient presenting with one eye, but you see the other eye also has macular BRVO. And they can even go into proliferative retinopathies silently. CRVO, when it presents with a disproportionately poor vision, often there may be a cilioretinal artery occlusion seen as retinal whitening, which can be picked up on the OCT angio. And this is the last slide. Retinal vein occlusions in young patients, generally very good prognosis, may not need any treatment, but if required, also generally one anti-VEGF injection is enough. The causes are inflammation, idiopathic, blood dyscrasias, or more often medication. Thank you.
Thank you, Mallika. I think she made very important points. First of all, you have to consider the younger patients and older patients separately. The younger patients, you have to look for a systemic cause and treat the underlying pathology. In the older patients, is usually not any other cause other than maybe hypertension or glaucoma. The other important thing was about the macular BRVOs, which are actually quite recalcitrant to treatment. Though they look like small problems, but they are recalcitrant problems. So that's the other important thing. Third is the role of laser, especially don't miss out extensive areas of capillary non-perfusion, especially in BRVOs which are requiring too many injections. There, laser could make a difference, in addition to the focal laser, which you may do later on. So these are some of the points which are very important. Any questions from the house or from the panel? Yes.
Initially, if you are neglecting, these will become
Chronic.
So we should stress on appropriate management of tributary BRVOs with macular edema. That is one important. The second is CRV with macular edema. Again, it's very, very resistant disease, and we should have an open mind for n number of injections. And maybe if it is required, you may have to add some photocoagulation in the periphery to facilitate or to reduce the number of injections as well.
Yeah, the other important thing is CRVO is a serious problem, a much more serious problem. BRVO is you can afford to be a little more comfortable in taking care of the patient. So don't be as aggressive in BRVOs. You'll just end up giving them injection after injection without getting any gain. So you also have to see what is the gain you're getting by giving very intensive treatment versus a more conservative regime. So keep that in mind when you're treating these patients.
Specific to RVO, I find multiple RVOs are very common. In the same eye, you may have 3 areas and the other eye 2 areas of BRVO, or silent RVOs, very common, which can lead to silent proliferative retinopathy, and they come with a disaster in the other eye while you were focused on the one eye.
Yeah, which is why the role of fluorescein angiography at least once.
Or at least careful exam of both eyes at every review.